Welcome back to this next video in which we are studying headaches. Okay, so we're currently in the process of trying to understand the different causes for intracranial hypertension. And we've been through the things that can cause too much CSF to be present inside the skull. We've been through now the things that can cause too much tissue to be present inside the skull. We now want to move on to the things that can cause too much blood to be present inside the skull. So I'll just put this as a little title here. We now want to talk about things that can cause the amount of blood inside the skull to become too high and thereby cause intracranial pressure to go up, which is called intracranial hypertension. So, what sort of things then can lead to the amount of blood inside the skull going up? Well, this is not rocket science, it's very simple. Hemorrhage leads to the amount of blood going up inside the skull. If you have a hemorrhage inside the skull, then what happens, of course, is one of the blood vessels breaks open and blood is going to leak out of that blood vessel into the surrounding tissue, and then you're getting blood accumulating in that place within the skull, and that blood is additional blood volume that you've now got inside the skull, so that's going to increase overall the amount of blood that you have inside the skull, because now you don't just have the blood vessels full of blood, you also have this patch of blood that has leaked out into the surrounding tissue. So, there is a fancy term then for bleeding inside the skull, and that is intracranial hemorrhage. So we are going to discuss the different types of intracranial, which of course just means within the skull, and then hemorrhage, which means bleeding. It's the fancy word for bleeding. Now, I'm spelling hemorrhage using the British English spelling of hemorrhage, which I admit is a stupid spelling, but it's the spelling that I've been brought up with. If you want to use the American English spelling of hemorrhage, obviously just get rid of the A and then have the more sensible spelling. So, intracranial hemorrhage, bleeding inside the skull, and of course we can abbreviate intracranial hemorrhage down to ICH for short, so be aware that this abbreviation ICH, it can be used to mean both intracranial hypertension and intracranial hemorrhage. So when you see it, you should always be trying to interpret, does this mean intracranial hypertension or does it mean intracranial hemorrhage? And of course you'll have to interpret it in context to work out which one it is actually intended to mean. So, intracranial hemorrhage then, of course there are a huge number of different blood vessels inside the skull, and we can get hemorrhages occurring in all of them. So we categorise hemorrhages according to the rough location where the blood that is leaking out of the blood vessel is going to actually be accumulating. So let me now show you the different types of intracranial hemorrhage and how we categorise them up. So, the first division that we make in our categorization of intracranial hemorrhages is to divide them all into extra-axial and intra-axial hemorrhages. So we've seen these words before. Remember, extra-axial means outside of the actual brain. So it means within the meninges. So we talked about earlier on the extra-axial brain arteries, which were those arteries that were running in the subarachnoid space. So an example was, of course, the anterior cerebral arteries. The posterior cerebral arteries were another example. All of those arteries that we spent so long discussing that were running in the subarachnoid space, they gave off branches that would then penetrate through the pia mater and become intraaxial and supply the brain parenchyma with blood, but they were actually outside of the brain parenchyma. They were in the meninges, and therefore we called them extraaxial brain arteries. Now, extraaxial actually refers to any blood vessel that is outside of the brain, i.e. in the meninges, so it also includes those meningeal arteries that we discussed earlier on, before we discussed the extraaxial brain arteries that were, remember, in the outer meningeal layers, so in the dura mater and the arachnoid mater. We didn't call those extraaxial vessels at the time, but you can refer to those as extraaxial meningeal arteries because they are outside of the actual brain parenchyma, they're in the meninges. So an extra-axial hemorrhage is going to be where you're going to be bleeding from an artery that is in the meninges, that is extra-axial, and therefore the blood is going to accumulate extra-axially. Right, so that's extra-axial, and then of course the opposite one is within the brain, so inside of the meninges, so inside of the pia mater, and this is intra intra-axial. And of course, we've discussed examples of intra-axial blood vessels as well. We saw that the middle cerebral artery for a while runs intra-axially within the brain parenchyma, and it gives off those lenticulostriate branches, which will also be examples of intra-axial blood vessels. So, if you have a hemorrhage from a blood vessel that is actually inside of the meninges, i.e. within the brain itself, then that's called an intra-axial intracranial hemorrhage. So, let's start from the outside and work inwards. So we'll start by discussing extra-axial intracranial hemorrhages, and we'll then go on to discuss intra-axial intracranial hemorrhages. So, extra-axial intracranial hemorrhages, these are going to be bleeds where the blood is going to accumulate in the meninges, the layers that line the brain, i.e. outside of the brain. Now, we divide extra-axial hemorrhages up into 3 different types, and the first thing I'm going to do is just write down what their names are. So, there are epidural hemorrhages, and we can refer to epidural hemorrhages for short as EDHs. There are subdural hemorrhages, and we can refer to subdural hemorrhages for short as SDHs. And then finally, there is subarachnoid hemorrhages, which we can abbreviate down to SAHs. Okay, right, so let me explain now what these different types of extra-axial hemorrhages are. So, the difference between them is where the blood is actually going to go, and also, of course, which blood vessels are actually going to be hemorrhaging to give rise to blood going into these areas. So epidural is the most outer one, so it's helpful for this to go back up to my picture, here we have it, of the meninges. So remember, this is the skull. This is the periosteal dura mater, this is meningeal dura mater here, and then we've got the arachnoid mater, then the subarachnoid space, and then we'll, of course, have pia mater covering the surface of the brain. Beginning with an epidural hemorrhage. Epi means around. Dural, of course, means dura mater. So this is going to be a hemorrhage where the blood is going to accumulate outside of the dura mater, in the potential space between the periosteal dura mater and the skull. So we know that the periosteal dura mater and the skull, you know, they're usually attached to one another, but you could open up a space in between the two. There is a potential space there. It's not usually filled with anything. Indeed, usually the periosteal dura mater is right up against the skull and attached to it. But if you wanted to force blood into this, you could push the two apart, you could force the two apart, and then you could get blood accumulating in this potential space, well now a realised space, between the periosteal dura mater and the skull, and that is called an epidural hemorrhage. So, what sort of blood vessels then have to actually break open in order to cause blood accumulation there? Well, hopefully you should be able to work this out. Which blood vessels did we say run in the outer layers of the meninges? Those meningeal arteries, which were examples of extra-axial arteries. Those meningeal arteries that we spent so long discussing. So remember, we had the middle meningeal arteries, they were the major examples, and they came off the maxillary arteries and then went through the foramen spinosum to get into the cranial cavity, and then they remained in those outer layers of meninges, and it's the same for the other meningeal arteries. They all remained in those outer layers of meninges. Now, if you have a hemorrhage from one of those, the blood can leak out of those meningeal arteries and can end up in this epidural space, and then it's called an epidural hemorrhage. Now, how do you actually end up then with a hemorrhage coming from one of your meningeal arteries? How do you actually end up with a hole in one of your meningeal arteries? Well, in order to get that, you need to have injured the artery, and that's usually by a traumatic injury. And when you have a head injury, such as banging your head, the fancy piece of terminology that we use is to call that a traumatic brain injury. So, for short, traumatic brain injury is abbreviated down to TBI. So this stands for traumatic brain injury. Okay, so a traumatic brain injury is going to lead to one of the meningeal arteries breaking open. Then the blood spurts out of that artery into the epidural space, and that leads to an accumulation of blood there, and that's called an epidural hemorrhage. Okay, and that's going to raise intracranial pressure. Now, of course, because it's an artery that has broken open there, the blood is going to accumulate in an epidural hemorrhage extremely quickly, and that's important in understanding the difference between the presentation of a subdural hemorrhage and the presentation of an epidural hemorrhage. Let me just, before I move on to subdural hemorrhage, give you one final piece of terminology. A piece of terminology that's very useful when we're talking about epidural and subdural hemorrhages, and also later on as well, is the concept of a hematoma. So, what this means is a mass of blood that has clotted. So when you get an epidural hemorrhage, blood accumulating in that epidural space, that blood is now going to become static, and when blood becomes static, it has a tendency to clot. So it will form a great big blood clot in that epidural space. When you have a great big mass of blood that is clotted like that, it's called a hematoma. So epidural hemorrhage will often result in a very quick forming epidural hematoma. And these epidural hematomas, they will cause raised intracranial pressure, so they'll cause intracranial hypertension and all the symptoms of intracranial hypertension that we've discussed. And they will also, of course, specifically press on the bit of the brain that is right over where the epidural hematoma is, and that can lead to neurological symptoms. It can lead to problems with the functioning of that bit of brain more than the other portions of the brain. Okay, so final comment on epidural hematomas is how do we actually treat epidural hematomas? Well, it's unlikely that if you have a very big epidural hematoma that it's going to go away on its own. So sometimes it requires surgical removal. So what you have to do is remove a piece of the skull bone, and that's called a craniotomy, where you open up the skull. So you perform a craniotomy, and then you surgically remove the hematoma, that great big mass of clotted blood, and then of course that will relieve the intracranial hypertension, and it will relieve the pressing on the portion of brain directly over the epidural hematoma. So craniotomy is sometimes used as the treatment for epidural hematoma if it's very large and if it's in a certain site that's causing big neurological symptoms. So let's now move on to subdural hemorrhage. So back up to the picture of the meninges then. So you might be able to guess what subdural hemorrhage is going to be. Epidural hemorrhage was outside, around the dura mater. Subdural, sub means underneath, so this is going to be a hemorrhage that's underneath the dura mater. So it's going to be a hemorrhage that's in between the dura mater and the arachnoid mater, specifically in between the meningeal dura mater and the arachnoid mater, this potential space here. Now, of course, usually that's just a potential space. It's not actually usually open. But again, if some blood vessel is bleeding into that potential space, then the blood would force that space open, and again you can get an accumulation of blood there that will again form a hematoma. So subdural hemorrhages can often lead to subdural hematomas. So the next question is, which blood vessels is it that generally actually cause subdural hematomas? Where is the hemorrhage? Well, this time you might be expecting me to say maybe it's the meningeal arteries again, because we know that they run in those outer meninges, and maybe if one's more inner than what we've discussed previously for an epidural hemorrhage, maybe if it's running in that gap between the dura mater and the arachnoid mater, then if that broke open, it could lead to a subdural hemorrhage. However, that's not the answer. The answer is that subdural hemorrhages are actually usually a hemorrhage from a venous blood vessel rather than from an arterial blood vessel. It's usually a hemorrhage from the bridging veins. So let me remind you what bridging veins were. So the bridging veins were veins that were draining the brain parenchyma, and they drain venous blood into the dural venous sinuses. And luckily we have a picture of a dural venous sinus here. This is representing the superior sagittal sinus. So remember, when we were exploring the dural venous sinuses, a big question that we had was, how on earth do you actually drain blood into these dural venous sinuses? And the answer was, it's the bridging veins that are responsible. These are veins that will come from the brain parenchyma, they'll penetrate through the pia mater, they'll go through the subarachnoid space, they'll go through the arachnoid mater, through the meningeal dura mater, and they'll empty their blood into the dural venous sinus. So that means that they go through this subdural space, they penetrate through the arachnoid mater and the meningeal dura mater. And if they were to break open at that point there, as they're crossing at that junction between the arachnoid mater and the meningeal dura mater, then that would lead to blood accumulating in the subdural space, and therefore would lead to a subdural hemorrhage. And indeed, these are the things that generally break open in subdural hemorrhages. So how do they break open? The answer is the same as for epidural hemorrhage. So it's traumatic brain injury or traumatic head injury. So again, traumatic head injury, either this can lead to an epidural hemorrhage or it can lead to a subdural hemorrhage. So in a subdural hemorrhage, rather than it breaking open a meningeal artery, you've been slightly luckier, it's broken open a bridging vein or multiple bridging veins that are draining into one of the dural venous sinuses. And this is going to accumulate now much slower because it's venous blood. Remember, when we're talking about arterial blood, that's at a very high pressure. So when you break open an artery, loads of blood is going to accumulate in that space much quicker. Whereas, if we're now talking about breaking open a vein, blood's going to come out of that vein much slower. So subdural hemorrhages are going to build up much slower than epidural hemorrhages. So this is a difference in the presentation between epidural hemorrhage and subdural hemorrhage. This one will be much slower in onset. So if you've had a traumatic brain injury and maybe you banged your head very badly and you've now got the symptoms of intracranial hypertension, then it's very important to try and ask whether it came on very quickly, and if it came on reasonably quickly, then it's more likely to be an epidural hemorrhage because the blood has accumulated much more quickly and raised intracranial pressure much more quickly. Whereas if it came on very slowly, then it's more likely to be a subdural hemorrhage because the blood has accumulated very slowly, and that suggests that it's a venous hemorrhage rather than an arterial hemorrhage. So again, in subdural hemorrhage, the blood will accumulate in that subdural space and can form a subdural hematoma. And again, if this is very big, not only will it give rise to the symptoms of intracranial hypertension, but it can also cause other neurological symptoms because of the portion of brain that it is over and it pressing down on that portion of brain particularly. And therefore, if it's very big and causing big neurological problems, then it may be necessary to surgically remove it, because usually these things do not go on their own. Hematomas are very bad for not going if we don't do anything. So again, we can surgically remove it by, again, removing a little piece of the skull and then going in and draining the subdural hematoma. So a craniotomy, again, can be the treatment for a subdural hematoma. Right, so that's epidural hemorrhages and subdural hemorrhages covered. Let's now go on to subarachnoid hemorrhages. So subarachnoid hemorrhages are a very famous cause of a horrendous headache. So let's firstly discuss where the hemorrhage is going to actually be. So it's reasonably obvious. The hemorrhage this time is going to be in the subarachnoid space, in this space here. We know that a huge number of arteries run in the subarachnoid space, and these arteries are going to be arteries that supply the brain with arterial blood, and that is significant because it means that if we're going to get a hemorrhage in one of those arteries, which is indeed what happens in a subarachnoid hemorrhage, then now blood from that artery is no longer going to be supplying the portion of brain that it usually supplies, and therefore subarachnoid hemorrhages, they can actually cause strokes. In fact, they are forms of strokes. They're one form of a hemorrhagic stroke. But I'll discuss this more in a moment. So, very simply then, subarachnoid hemorrhage means that you're going to get hemorrhage into the subarachnoid space. So the blood is now going to go into the subarachnoid space. Now, when this occurs, it causes a very characteristic headache, a horrendous headache that comes on instantly, really sudden onset, far more sudden onset than the headache that you would get from an epidural hemorrhage. And this is so sudden onset and so severe that it's described as a thunderclap headache. So it comes on like a clash of thunder, really sudden, and then it's there clashing. I'm just going to tidy up the board a bit by getting rid of these little dots here. Okay, so subarachnoid hemorrhage is described as the worst headache anyone's ever experienced. It's a horrendous headache that comes on extremely suddenly. And this headache that is produced by a subarachnoid hemorrhage, it cannot just be explained by saying, okay, when you have a subarachnoid hemorrhage, blood is going to accumulate in the subarachnoid space, raising intracranial pressure and causing intracranial hypertension, and therefore a headache. No, it can't be explained just by that. That will be contributing to the headache. However, really, the thing that causes the massive headache that comes on extremely suddenly is the fact that when you have blood in the subarachnoid space, that blood is capable of directly activating meningeal nociceptors. So remember, meningeal nociceptors in the subarachnoid space will mainly be in the perivascular connective tissue, the walls of arteries. So imagine loads of blood leaking into the subarachnoid space and then going around the arteries in the subarachnoid space and activating the meningeal nociceptors in the walls of those arteries in the subarachnoid space directly. And that is why they cause this massive headache that comes on extremely suddenly, because the blood in the subarachnoid space can directly activate subarachnoid space meningeal nociceptors. Okay, and of course this headache is going to be bilateral and it's going to be all over because the blood is going to very quickly spread all over the subarachnoid space, all over the brain, and therefore it will be activating meningeal nociceptors again all over the brain. So it will lead to a bilateral headache, which will be in the frontal regions, the periorbital regions, the temporal regions, and the occipital regions. And this is going to be an extremely severe headache because the blood causes huge activation of the meningeal nociceptors. Accompanying symptoms that you'll get with it are, of course, you'll get nausea and vomiting, as indeed we understand you'll get whenever you've got horrendous pain. And you also get pronounced meningeal symptoms. And again, that's because you have caused such huge amount of activation of the meningeal nociceptors by the blood actually going into the subarachnoid space. Okay, so more things that I want to discuss then. So we now understand why subarachnoid hemorrhage produces this thunderclap headache. It's because the headache isn't just coming from the rise in intracranial pressure. Of course, that will be contributing. It will cause a rise in intracranial pressure because now you're getting blood accumulating in the subarachnoid space, which will raise intracranial pressure, and that will be activating the meningeal nociceptors as well. But in addition to that, the blood directly activates the subarachnoid space meningeal nociceptors, and that's what makes the headache so severe and so sudden in onset. Okay, and you get the pronounced meningeal symptoms because you've got so much activation of meningeal nociceptors. So that explains the type of headache that you get in subarachnoid hemorrhage. Let's just explore a little bit more what's actually going to happen in subarachnoid hemorrhage. So, in subarachnoid hemorrhage, usually the reason that one of these extra-axial brain arteries in the subarachnoid space has broken open is that a berry aneurysm within that blood vessel has broken open. So let me explain what is known by a berry aneurysm. So usually it's berry aneurysms that are the cause of subarachnoid hemorrhages, ruptured berry aneurysms. So let me just make sure I spell aneurysm correctly. Aneurysm, I think that's correct. Okay, so berry aneurysms. What is a berry aneurysm? Well, of course, firstly we need to answer the question of what is an aneurysm. An aneurysm is a dilated portion of a blood vessel, and it's been formed by the wall of the blood vessel being weak and being pushed open or pushed to expand by the pressure of the blood inside. So let me draw a normal blood vessel. So here's a nice normal blood vessel, a nice tube. Now, let's imagine that this portion of the wall here has become extremely weak. What can now happen is an aneurysm can form there, and the pressure in the blood vessel of the blood, of course, can lead to the wall expanding out, engorging, ballooning. So what can happen is this can start looking like this. So you get a ballooning of the wall of the blood vessel. And that's because the wall of the blood vessel was initially weak and it could not withstand the pressure, so it ended up ballooning like that. And that's what is known as an aneurysm. When blood vessel walls balloon like this, it's called an aneurysm. And aneurysms can occur all over the cardiovascular system. Now, When they occur in the extra-axial brain arteries in the subarachnoid space, they tend to be reasonably small aneurysms. You know, they're not like the massive things that can occur in the abdominal aorta. They're generally quite small, the sort of size of a berry, and hence they're called berry aneurysms. So, blood vessels, arterial blood vessels in the subarachnoid space, they can develop berry aneurysms because the wall has become weak. So if someone has berry aneurysms on extra-axial brain arteries in the subarachnoid space, this puts them at risk of subarachnoid hemorrhage, because usually a subarachnoid hemorrhage arises when a berry aneurysm bursts, basically. So aneurysms are at risk of popping. That's the big problem with them. So, they can pop just spontaneously, or they can pop following a traumatic brain injury. So subarachnoid hemorrhage, it can either be caused by traumatic brain injury, breaking open a berry aneurysm, or it can be caused just by a berry aneurysm breaking open spontaneously, so spontaneous rupture of a berry aneurysm. Okay, so that's normally what happens to actually trigger a subarachnoid hemorrhage, that you have pre-existing berry aneurysms, and one of these berry aneurysms is going to rupture within the subarachnoid space following traumatic brain injury, or potentially just spontaneously it ruptures, and that will leak blood into the subarachnoid space, and that's going to cause the thunderclap headache, and then of course also raised intracranial pressure and the intracranial hypertension headache accompanying the thunderclap headache. But it will be contributing to, of course, the thunderclap headache. Now, before we move on to discussing the treatment for subarachnoid hemorrhage, let's just talk about the fact that subarachnoid hemorrhage is a form of stroke. So, subarachnoid hemorrhage, unlike epidural hemorrhage and subdural hemorrhage, is actually a form of stroke. And the reason is, of course, that this is occurring in a blood vessel that is actually going to supply the brain. Remember what a stroke is. A stroke is where a great big portion of the brain dies or gets very close to dying because of lack of blood supply, because of insufficient blood supply. Now, epidural hemorrhages and subdural hemorrhages, those were not hemorrhages from arteries that were going to supply brain material. Therefore, they're not going to lead to a stroke. They're not going to lead to a portion of brain material not getting enough blood. So they are not forms of stroke, whereas a subarachnoid hemorrhage, because it's occurring in a blood vessel that's actually supplying blood to the brain, it's a form of stroke. So let me just remind you of the different forms of stroke. So we divide strokes into two major different categories. There are ischemic strokes, and then there are hemorrhagic strokes. So ischemic and hemorrhagic. So let's just begin briefly by talking about what an ischemic stroke is, and then we'll talk about the one that's important to us, which is hemorrhagic stroke. So an ischemic stroke, remember, that's when a blood vessel becomes blocked. So when a blood vessel becomes blocked by a blood clot, usually, that is going to lead to the blood no longer being able to get through that blood vessel, and therefore the brain parenchyma that blood vessel supplies is not going to be receiving adequate blood supply, and then is going to die. So that's one way that a stroke can occur. That's called an ischemic stroke, and that occurs because a blood vessel has been blocked. And ischemic strokes, we can divide them into two separate categories: those that are thrombotic and those which are embolic. So two different types of ischemic strokes: thrombotic strokes and embolic strokes. In a thrombotic stroke, the blood clot that is blocking the artery is formed there. So in that artery, something caused a blood clot to form there. And the fancy word for a blood clot is a thrombus. So that's why this is called a thrombotic stroke. So when the blood clot actually forms in the artery that it's going to block, that's called a thrombotic stroke. And that's a form of ischemic stroke, because now it's going to block the artery and blood is not going to be able to get to the portion of the brain that that artery supplies, and therefore is going to end up dying, and that's what we call a stroke. An embolic stroke is where the blood vessel is going to be blocked by an embolus rather than a thrombus. And let me again just write down some of these key terms. So thrombotic stroke involves the formation of a thrombus there and then. An embolic stroke involves emboli, singular embolus. So an embolus is something within the bloodstream, usually again a blood clot, but this time it's moving around in the bloodstream. So in an embolic stroke, the blood clot is going to be formed somewhere far, far away from the actual artery in the brain that it's going to block, and then it's going to move in the bloodstream, which is when it's called an embolus, when you've got something moving around in the bloodstream that is capable of blocking arteries. That's what we call an embolus. So it's going to move around in the blood vessels, up the common carotid arteries, into the internal carotid arteries, and then into arteries that are going to supply the brain usually, and then it will block one of those arteries and then cause an ischemic stroke. So often, emboli that will end up going up to the brain can either be formed in the heart, maybe if you've got atrial fibrillation or a prosthetic heart valve and you haven't been taking your anticoagulant medication, warfarin, maybe as reliably as you should have, then thrombi can form there, and then they can whiz off there, they can break off there and then go whizzing up to the brain, block an artery in the brain, and that will cause an ischemic stroke because no longer will blood supply get to the portion of the brain that that artery supplies, and that's now called an embolic stroke, to contrast it to a thrombotic stroke where the blood clot was actually formed there. Okay, so those are ischemic strokes. We're not really interested in ischemic strokes. The type we're interested in is hemorrhagic stroke, and this is where blood vessels that supply the brain with blood are going to break open, they're going to hemorrhage, and when the blood is all leaking out of the blood vessel, of course, it's no longer going to be going forward to the brain material that it actually supplies, and therefore that brain material that's supplied by this hemorrhaging artery is going to die. Therefore, it's going to be a stroke. So hemorrhagic stroke is the type that subarachnoid hemorrhage is going to fall under. So subarachnoid hemorrhage is an example of a hemorrhagic stroke. There are two different forms of hemorrhagic stroke. One is subarachnoid hemorrhage and the other is intraparenchymal hemorrhage, which we'll come on to when we discuss intra-axial intracranial hemorrhages in just a moment. So, be aware then that when someone suffers a subarachnoid hemorrhage, it is a form of hemorrhagic stroke because all the blood from that artery is now coming into the subarachnoid space, and it will no longer be delivering oxygen and taking away carbon dioxide and delivering nutrients to the portion of brain that it's supposed to be delivering those things to, and therefore that portion of brain can end up dying. So you'll get neurological symptoms most likely as well with a subarachnoid hemorrhage. You'll get the symptoms of a stroke. Right, so now let's discuss the treatment then for subarachnoid hemorrhage. So how can we treat subarachnoid hemorrhage? Well, the first thing to say is that a lot of people who have a subarachnoid hemorrhage are actually going to end up dying. It's got a very high fatality. I think it's around half of the people who suffer from a subarachnoid hemorrhage will end up dying, I'm afraid. And the reason for that is because it generally leads to a massive hemorrhagic stroke. The arteries in the subarachnoid space that can break open are generally very big arteries, and therefore they will be supplying a lot of brain material. So when they break open and bleed into the subarachnoid space, that means that a large amount of brain material is no longer going to be receiving blood, and therefore it's going to lead to a rather major stroke, and that can lead to quick death. However, the people who do survive the subarachnoid hemorrhage, they can then go on to get complications from it afterwards, and we're now going to discuss how we can treat those complications. So of course, one of the major complications that can occur afterwards, after having a subarachnoid hemorrhage, is that the blood that is in the subarachnoid space is going to then lead to a communicating hydrocephalus. So remember back when we were talking about too much CSF, remember there were two different forms of hydrocephalus. Non-communicating hydrocephalus, which is where tubes in the ventricular system were going to be blocked, and communicating hydrocephalus, which is where there was a problem with the resorption of CSF at the arachnoid granulations. And that was usually because there was a problem with the consistency of the CSF. And they said that one of the things that could cause a problem with the consistency of the CSF is if there is blood in it. So here we now have a pathophysiology that can lead to blood being present in the subarachnoid space, fluid, the cerebrospinal fluid there. If you have a subarachnoid hemorrhage, blood will be in that CSF, and that's now going to block the CSF being resorbed. So this can now lead to a communicating hydrocephalus then, and this of course will make the intracranial pressure, which was already elevated because of all the blood now in the subarachnoid space, it can lead to it going even higher. Now, I should stress that imminently, when you have the subarachnoid hemorrhage, of course, blood is coming out of the blood vessel and that's causing the hemorrhagic stroke. If you survive the hemorrhagic stroke, then what will have happened is the artery will have sealed the gap in its wall, i.e. hemostasis will have occurred, and now blood supply to that portion of brain will be improving, and therefore the stroke we don't need to worry about anymore. You're going to have to recover from that, of course. You'll be left with major neurological symptoms, but you're not imminently going to die anymore because parts of the brain are dying. The blood supply has been restored. Yes, of course, there might be lasting brain damage. There's likely to be lasting brain damage, but at least blood supply has now been restored. So the major complication now is that you can get this communicating hydrocephalus, which can raise intracranial pressure through the roof. So let's now discuss this then. So what the subarachnoid hemorrhage, as you can see, it's more complicated than epidural hemorrhage and subdural hemorrhage because there are all sorts of things that can go on here. So this, if you survive it, and I'm going to put here, half of people will die. So half of the people who suffer from a subarachnoid hemorrhage die. Half of people die. But if you do survive it, then of course what must have happened is the blood vessel that had the hole in it that was hemorrhaging, it must have somehow filled in that gap. Hemostasis must have occurred, a blood clot must have actually formed in the hole, and therefore the blood vessel's integrity has been restored and blood supply to the portion of brain that it supplies will now be restored. Excellent. What can then happen after that is that you can end up, however, with really bad intracranial hypertension because you can develop a communicating hydrocephalus. So I'll write this down here. So a communicating hydrocephalus, which is where there is a problem with the resorption of CSF by the arachnoid granulations. And it's because of all the blood that is now present in the subarachnoid space. So the question is, how are we going to stop this causing intracranial pressure going up and up and up, and therefore developing worse and worse intracranial hypertension? And the answer is that temporarily, of course, we can prescribe them acetazolamide. So we can temporarily use acetazolamide here. And of course, that will stop the production of more CSF. So that will help stop the rise in intracranial pressure, but more long term we need to be removing that blood from the subarachnoid space so that we can get the cerebrospinal fluid system working properly again. How can we actually remove that blood? Well, what we put in is something called a ventricular drain. And this is a drain from the ventricular system. So this often goes into one of the lateral ventricles, and it's going to drain cerebrospinal fluid from the lateral ventricle. So if I go back up to my picture here, so it's inserted usually by a neurosurgeon, and what it effectively is a tube that will go into the lateral ventricle, and it's only a temporary tube. When we were talking about shunts earlier for non-communicating hydrocephalus, that was a permanent tube that was going to be inserted. This ventricular drain is a temporary tube. So we put in a temporary tube into one of the lateral ventricles, and this will be draining cerebrospinal fluid from that lateral ventricle gradually. And of course, all of the subarachnoid space cerebrospinal fluid and the ventricular cerebrospinal fluid is in continuum with one another. Therefore, the blood in the subarachnoid space will gradually make its way into the ventricular CSF, and therefore if we leave the ventricular drain in, it's going to eventually drain all of that cerebrospinal fluid with the blood out, and therefore eventually we will end up removing all of the blood from the cerebrospinal fluid, and once that blood's removed, then we'll just have normal CSF back again, and the communicating hydrocephalus will no longer be a problem, so we can stop the acetazolamide and hopefully remove the ventricular drain, and the person will not get communicating hydrocephalus, so they won't get horrendous intracranial hypertension. Okay, so that is subarachnoid hemorrhage discussed then. So remember, subarachnoid hemorrhage is this classic thunderclap headache, an extremely sudden, extremely horrendous headache, along with potentially major neurological symptoms from a hemorrhagic stroke. And the reason you get such a horrendous headache so quickly is because the blood in the subarachnoid space is capable of directly activating meningeal nociceptors. This headache is not justifiable just from the rise in intracranial pressure that the blood being present in the cerebrospinal fluid in the subarachnoid space produces. It's because of direct activation of the meningeal nociceptors by the blood. Okay, right, so now let's go on to intra-axial intracranial hemorrhages. So there are two different types of intra-axial intracranial hemorrhages, which I'll put down here. So intra-axial, remember, means inside of the meninges, so inside of the actual brain. And there are two different types of hemorrhages here. There is intraparenchymal intra-axial hemorrhages, which means inside the actual brain parenchyma. So intraparenchymal intracerebral hemorrhages, so inside the actual brain tissue. So for instance, if you've got a hemorrhage from that portion of the middle cerebral artery that is intra-axial, that would be an example of an intraparenchymal intra-axial intracranial hemorrhage, because that blood vessel actually is running through brain parenchyma. The other form of intra-axial intracranial hemorrhage is intraventricular hemorrhage, which means inside one of the ventricles. So you can also bleed into one of the ventricles. So let's firstly discuss intraparenchymal intra-axial hemorrhage, and this is the other form of hemorrhagic stroke. So hemorrhagic strokes, there are two different forms, subarachnoid hemorrhages and then intraparenchymal intra-axial intracranial hemorrhages, which is a hemorrhage from one of these intraparenchymal blood vessels that is supplying the brain. So, again, this generally is going to occur following the rupture of a little aneurysm. Now, the aneurysms that generally rupture to cause an intraparenchymal hemorrhage are generally much, much smaller than the ones that can rupture to cause a subarachnoid hemorrhage, and these have a name as well. They're called Charcot-Bouchard aneurysms. So this is both French names, so you don't pronounce the last letters. So Charcot is how you pronounce that rather than Charcot, and then Bouchard is how you pronounce that rather than Bouchard. So Charcot-Bouchard aneurysms. Now these are absolutely tiny little things. Berry aneurysms, they were actually a size that you could see. They were about the size of a berry, and therefore they were occurring on reasonably big arteries. Charcot-Bouchard aneurysms are tiny little aneurysms occurring on tiny little blood vessels. So let me try and draw this here. So here's a tiny little blood vessel, and here this little expansion there, that's representing a tiny little Charcot-Bouchard aneurysm. So generally, intraparenchymal hemorrhages are caused by the rupture of these tiny little Charcot-Bouchard aneurysms. So this is going to rupture, and again it can be ruptured either spontaneously or due to traumatic brain injury. And of course, when it ruptures, it's going to lead to blood accumulating in the surrounding tissue, so you'll get an intraparenchymal hemorrhage, and indeed that might form a mass that we can call an intraparenchymal hematoma, so you can get intra-axial hematomas as well as these examples of extra-axial hematomas that we've been discussing. So you can get a hematoma actually inside the brain parenchyma. Now, generally, intraparenchymal intra-axial hemorrhages, the type of hemorrhagic stroke that they produce is generally not going to be as bad necessarily. You see, the reason is that this is a much smaller little artery, so the amount of brain material that this supplies is going to be much smaller. So generally, the reality is that if this bursts and the portion of brain that this supplies is no longer going to be given blood, then that's a much smaller portion of the brain that's actually going to undergo the stroke and is going to die. Therefore, hemorrhagic strokes, generally it's the subarachnoid hemorrhagic strokes that are worse than the intraparenchymal hemorrhagic strokes, because of the fact that the aneurysms that break in intraparenchymal hemorrhages are so much smaller and are on such smaller arteries than the aneurysms that break in subarachnoid hemorrhages. Okay, so you can leak blood into the surrounding brain tissue, and this can lead to raised intracranial pressure. It can also lead to the symptoms of a stroke, as we discussed, because again it's a form of hemorrhagic stroke. And of course, the other problem is that it can form a hematoma inside the brain parenchyma. And again, this hematoma is unlikely to resolve without treatment. It's unlikely to go away on its own. So if it's in a particularly troublesome area and is causing particularly bad neurological symptoms because it's pressing on the surrounding brain material, then it can be removed by brain surgery again. So all of the types of hemorrhages that can lead to hematomas, epidural hemorrhage, subdural hemorrhage, and indeed the intraparenchymal hemorrhages, these can all be treated with brain surgery if necessary because the hematoma is unlikely to go away on its own. Finally, let's discuss intraventricular hemorrhages. So this is obviously a bleed of an artery into the ventricles. So some artery very close to the ventricles is going to break open and bleed into the ventricles. And this almost always is caused by traumatic brain injury. So traumatic brain injury occurs that's going to lead to a blood vessel very close to the ventricles breaking open, and then you'll get blood going into the ventricles. And again, this can lead to raised intracranial pressure and therefore the symptoms of intracranial hypertension. Now, again, this has the potential to lead to the symptoms of communicating hydrocephalus, because again you're leaking blood into the subarachnoid space cerebrospinal fluid, and therefore that's going to damage the resorption of the cerebrospinal fluid at the arachnoid granulations, and therefore as a complication of this you can again get communicating hydrocephalus. So again we need to remove the blood if there's a lot of it from the ventricular system, and therefore intraventricular intra-axial hemorrhages can be treated with a ventricular drain. So I'll put that here, this can be treated with a ventricular drain. Okay, and we have now finished our discussion of the different causes of too much blood being present inside the skull. So, to summarise what we have seen then, so we have seen that intracranial hemorrhages can be categorised into these two categories: extra-axial intracranial hemorrhages and intra-axial intracranial hemorrhages. Extra-axial is, remember, outside of the actual brain in the meninges. Intra-axial is inside of the brain, so within the meninges. So there are three different types of extra-axial intracranial hemorrhages, namely epidural, where it's around the dura mater, and this is generally caused by the rupture of a meningeal artery. Subdural hemorrhages, which is underneath the dura mater, in between the dura mater meningeal layer and the arachnoid mater, and that's generally caused by hemorrhage of a bridging vein. And then subarachnoid hemorrhage, which is caused by the breaking open of a blood vessel that is in the subarachnoid space and is one of those extra-axial brain arteries, and that therefore is a form of hemorrhagic stroke. Then, intra-axial hemorrhages, we divide these into intraparenchymal and intraventricular hemorrhages. In intraparenchymal hemorrhages, the bleed is actually inside the brain parenchyma, and this can lead to an intraparenchymal hematoma forming, and again this obviously will lead to a form of stroke, a form of hemorrhagic stroke specifically. And then finally, intraventricular hemorrhages, which is where the blood is going to go into the ventricles, and again that's the main complication that can occur with that is that you can end up with communicating hydrocephalus, and therefore we need to treat that with a ventricular drain. So all of these different forms of intracranial hemorrhages, they will lead to the amount of blood inside the skull going up, and therefore they will lead to intracranial pressure going up, and therefore they can lead to the symptoms of intracranial hypertension. Okay, so we have now discussed lots of different causes of intracranial hypertension. We have seen how you can end up with too much CSF, we have seen how you can end up with too much tissue inside the skull, and we have seen how you can end up with too much blood inside the skull in these intracranial hemorrhages. The last thing that I want to discuss with regards to intracranial hypertension is something called idiopathic intracranial hypertension. So let's go down here and discuss idiopathic intracranial hypertension. I think I'll get a new exciting colour to do this in. We'll go for orange. Okay, so the final form of intracranial hypertension that we need to discuss is idiopathic. Now remember, whenever you see idiopathic, it means that the origin of this is unknown. We don't understand this at all. We don't understand where the intracranial hypertension is coming from. So whenever you see idiopathic, it means that we don't understand it. We don't understand why it's present. So idiopathic intracranial hypertension. So this is where intracranial pressure is far too high. So you do have intracranial hypertension, however, we cannot find a cause for your intracranial hypertension. It does not seem to be that you have too much CSF. It does not seem to be that you have too much brain tissue, and it does not seem to be that you have too much blood inside the skull. So we do not know what is causing your intracranial hypertension, but it is there. You do have too high intracranial pressure, but we don't know why. And that's what the idiopathic means, that we don't understand where the intracranial hypertension has come from. And for short, idiopathic intracranial hypertension can be abbreviated down to IIH for short. Now, be aware that there was an old name for idiopathic intracranial hypertension. It used to be called benign intracranial hypertension, and that can be abbreviated down to BIH. So you may well see people talking about benign intracranial hypertension. That's kind of a bad name, which is why it's been dropped, because benign suggests that it's not a problem. However, this is a problem. You will have the symptoms of intracranial hypertension, and it can indeed cause you to go blind, just the same as all the other forms and all the other causes of intracranial hypertension can cause you to go blind. So this is really not benign. We have renamed it idiopathic intracranial hypertension, which is a better name for it. So, a little bit of epidemiology then. Idiopathic intracranial hypertension affects around 1 in 100,000 people. And the people generally affected by idiopathic intracranial hypertension, and it's roughly around 9/10 of the cases of idiopathic intracranial hypertension, are women of childbearing age. So women of childbearing age, so they're currently in the age where they could become pregnant, so of childbearing age, who are overweight. So that's the major class of people that idiopathic intracranial hypertension occurs in. So it's extremely rare. 1 in 100,000 people are affected by idiopathic intracranial hypertension, and 9/10 of the cases of idiopathic intracranial hypertension are usually young women of childbearing age who are overweight. However, in the other cases of idiopathic intracranial hypertension, generally what you can find is that they're on certain drugs. There are certain medications that can lead to idiopathic intracranial hypertension. And by the way, I can't give you the pathophysiology behind idiopathic intracranial hypertension. The whole point is that we don't understand why they have intracranial hypertension. I can only tell you these very basic facts, that it occurs in 1 in 100,000 people, that you get intracranial hypertension with no apparent cause, and that generally the people who get it are women of childbearing age who are overweight. However, there is an important fact to know about here, that certain drugs are acknowledged to be able to cause idiopathic intracranial hypertension. And there is one class of drugs in particular that you should know about that can lead to idiopathic intracranial hypertension, and it is the retinoids. So if you haven't heard of this class of drug before, retinoids are drugs that are vitamin A derivatives. That's what links them all. They're all drugs that are very similar in structure to the molecule vitamin A. Now, retinoids are commonly used by dermatologists, skin doctors. There are loads of different retinoids that are effective at treating different skin conditions. They can also be used in oncology and hematology for treating certain forms of leukemia as well. However, the most famous retinoid, the one to know above them all, the one that is very, very famous, is the drug isotretinoin, which is used to treat acne. So it's used by dermatologists to treat acne, and it is incredibly effective at treating acne. Many people take this drug for 5 months, or 5 to 7 months, and then after they finish the drug, they no longer have a single spot, and then they will never get another spot in their life. It is the closest thing we have to a cure for acne. So it's an extremely effective drug. It's more commonly known by its famous brand name, and this is another very famous drug, and it's called Accutane. So I said earlier on that Prozac was a very famous drug because it was the antidepressant, the SSRI, given to teenagers. Again, Accutane is a very famous drug, and it is again a drug that is given to teenagers for acne. So isotretinoin is an extremely famous example of a retinoid, a drug that is derived from vitamin A, and it's used by dermatologists to treat acne, and its initial brand name, I think it's no longer actually produced under this brand name, was Accutane, and that's often the name that people use for it. So be aware that this class of drugs, the retinoids, including this drug isotretinoin, and there are loads of other retinoids as well, used to treat other skin conditions, and indeed others, for instance tretinoin, all-trans retinoic acid, is used to treat certain forms of leukemia as well. So be aware that they're not just used to treat used as treatment in dermatology, but also in other specialities as well. But this class of drugs is one particular class of drugs to be aware that can lead to idiopathic intracranial hypertension. There are some other classes of drugs as well that are famous for causing idiopathic intracranial hypertension, but this is easily the most famous example. Okay, and that's really all I can say about idiopathic intracranial hypertension. Actually, I can say a little bit more. I can tell you about what can we do to actually help idiopathic intracranial hypertension. We do not understand how these drugs lead to idiopathic intracranial hypertension. The whole point of idiopathic intracranial hypertension is that there isn't too much CSF, apparently, there isn't too much brain tissue, and there isn't too much blood. So what can we do? Well, of course, even though we don't think there is too much CSF, we can still give acetazolamide to reduce the amount of CSF. Applying the Monro-Kelly doctrine, if we reduce the amount of CSF, we will reduce intracranial pressure, and that's what we need to do to get rid of the symptoms of intracranial hypertension and to reduce the risk that sight is going to be damaged. So, the treatment for idiopathic intracranial hypertension will be acetazolamide or another carbonic anhydrase inhibitor to reduce the amount of cerebrospinal fluid being produced by the choroid plexus. If we reduce the amount of CSF, then of course we will bring down intracranial pressure. Now, in the 9/10 of cases of idiopathic intracranial hypertension, where it's women of childbearing age who are overweight, then losing weight is often helpful for getting rid of the idiopathic intracranial hypertension and can indeed cure it in many cases. So losing weight is a good treatment strategy for these people where it is occurring in women of childbearing age who are overweight. If, of course, we believe it is a drug that is causing it, so if someone is indeed on a retinoid drug such as isotretinoin, then of course the treatment will be, we're going to have to take you off that drug and see if it gets better and see if therefore it was that drug that was leading to the idiopathic intracranial hypertension. Okay, so that's all I can say about idiopathic intracranial hypertension. We do not understand the pathophysiology, but somehow you get intracranial hypertension without having too much CSF, without having too much blood, and without having too much brain wheat somehow. And it's very rare. It occurs in 1 in 100,000 people. The major group of people it occurs in are women of childbearing age who are overweight, and losing weight is often helpful as a cure for that. We can temporarily treat you on acetazolamide to reduce your intracranial pressure. If it's occurring in someone who isn't a woman of childbearing age who is overweight, then look very carefully at what drugs the person is on. Particularly look to see if they're taking any retinoids, because retinoids famously can lead to this as a rare side effect. So, that completes our discussion of intracranial hypertension as a cause of a headache. In the next video, we'll go on to low pressure headaches, intracranial hypotension, and then we'll go on to meningitis.